Historically, when a person entered a behavioral health crisis, their or their family member's only option was to call 911. But let's consider for a moment, what are the options of crisis response? And even more important, what would be the most effective response to a behavioral health crisis? For the past several decades, we have discussed the importance of diverting those with behavioral health care needs away from the criminal justice system and into the behavioral health system of care. But what does that mean? When can we begin the diversion process? We know that the majority of calls that are made to a 911 center regarding behavioral health crises do not require an armed law enforcement response. So, can we begin to divert many of those calls for service without ever sending law enforcement officers? And when there needs to be a response, does it always have to be law enforcement? As we take a closer look at crisis response, we can divide response between two distinct and separate systems. 911 represents emergency services and the gateway to the criminal justice system. Crisis line services, such as 988, represent behavioral health care services and serve as the gateway to the behavioral health care system. Many times we try to integrate these two systems, but is that needed? Could it be more effective to keep the separation of the two systems, but connect them when appropriate? Again, understanding that most calls for service to 911 regarding a behavioral health crisis do not require a law enforcement response. And also understanding that the majority of crisis calls received by a crisis line service, reported to be between 85 and 98%, are resolved telephonically without sending anybody into the field, we can begin to divert calls at this level. We can train 911 call takers to identify that a call is regarding a behavioral health issue, begin the de-escalation process, and then triage the call to determine the most appropriate response. If it is decided that a law enforcement response is not warranted, then the call taker can complete a warm handoff to a crisis line service. The crisis line counselor can conduct a secondary triage and complete a warm handoff back to 911 if it is determined that there is a level of danger that requires law enforcement assistance. Otherwise, the crisis line can handle the call. In addition to the crisis line being able to handle most emergent calls for help, many crisis lines include the additional component of a warm line service. A warm line is generally staffed by certified peer specialists and provides an empathetic ear, support, and resources. Another benefit of a warm line service is that they can make connections with persons who struggle with mental health symptoms who continually call 911, only to have law enforcement respond and determine the complaint was unfounded. These continual calls into 911 can be decreased by connecting such persons to a warm line. And after the peer counselor builds rapport, they can offer the person the opportunity to call them instead of 911 when they begin to experience the same symptoms or just need someone to talk to. Now, we understand that we will not be able to resolve all calls telephonically, so sooner or later, we will need to send support into the field. On the 911 side, we can already dispatch emergency medical services and/or law enforcement. But what we must now begin to focus on for all communities is a non-law enforcement response option. Even if a community is successfully utilizing an embedded co-response model that places a law enforcement officer and a mental health clinician into the same vehicle to respond to calls for service, a non-law enforcement option will assist in reducing the requirement that law enforcement respond to all calls and can often be more effective, cost-efficient, and less stigmatizing. Mobile crisis teams are often made up of a combination of three disciplines. They combine the skills of a behavioral health crisis counselor with a certified peer specialist or medical personnel such as a paramedic, EMT, or an RN. Sometimes the team is made up of all three disciplines. But let's not discount the benefit of having law enforcement as part of a co-response when law enforcement support is warranted. Just as we connected the two systems at the 911 crisis line level, we can connect the two systems at this level as well. If we make certain that we have a cadre of patrol officers trained as CROs, crisis response officers, where they are responsible for patrol services but become primary responders to those crisis situations warranting law enforcement intervention, and we train those CROs how to work with the mobile crisis team, and we train the mobile crisis team members how to work with the CROs, then we can realize the benefit of co-response with law enforcement, but only when warranted. Now, just as we are not able to resolve all calls telephonically, we will not be able to resolve all calls for service by just sending out teams into the field. Sooner or later, we will need to have some place to take someone for assistance. We already have hospitals as an option on the 911 side, but is that the best option for a person in crisis? Think about the last time you were in a hospital emergency room. Most are very hectic with loud noises, buzzers, bells, and intercom announcements. Some people crying, others laughing, others groaning, and many talking. Most are stark white and often bright with light. Experts agree that this is not the most suitable environment to address the needs of a person experiencing a behavioral health crisis. Instead, we need to consider an alternative environment where a person in crisis can be treated. We must consider developing crisis stabilization centers. Crisis stabilization centers adhere to the home-like, non-hospital environment. Instead of beds and gurneys, they have recliners. Instead of loud and bright environments, they have subdued sounds, softer colors on the walls, and dimmer lighting. They create environments that handle the crisis at the tempo of the person and not the speed of the facility. This is not to fault hospital emergency rooms. After all, ERs are designed to get a person in, get them triaged, get them stabilized, then get them discharged or handed off to a specialist as quickly as possible. Of course, not all communities can afford to have a freestanding crisis stabilization center, so another option is to develop access centers. Access centers are generally part of a hospital, but in a separate area from the ER. An access center abides by the same home-like, non-hospital environment as the crisis stabilization center and addresses the crisis based on the needs of the person and not the speed of the facility. Following these best practices of crisis response, communities will be certain of having a crisis response system that is the most compassionate, most effective, and least intrusive in the lives of those who may experience a crisis.